No, as I said, we're trying to draft this program, and we're trying to walk through this whole process from start to finish. So if something jumps out at you that we've missed and we need to consider, please, feel free to let us know, and then we can add it directly into this document and then take it back and start to flesh that out as well. Okay?
All of that said, our goal is to make it easy for providers to provide care to the patient and not be spending hours on paperwork, okay, and getting already out from under paperwork. So starting out, it starts with billing, with providing care, it starts with scheduling. So if we can get schedulers, kind of asking patients a little bit more about why they're coming in, that follow-up doesn't work. If it's mentioning pain, strain, trauma, go ahead and ask, is this related to an on-the-job injury? Is there workers' compensation? Okay? So you can find that out before they come in. You can verify the employer, the date of injury, and start to build the case. So we talked about the case last month, or it was May, I guess, two months ago now. So in May we started talking about the cases, attaching those cases before they come in. Do you guys have a handout from before, you remember? Attaching the cases, looking at self-insureds. Okay. Okay. Yeah. Okay. So if the patient has a new injury and they have not been seen at Sound for that injury, ask if they have a claim number, date of injury, current employer. Note that on your account and your schedule. Proceed with scheduling if the injury was in the last 48 hours for new L&I claims.
So that's kind of a new consideration.
Yes. So we're looking at only taking new injuries if they have not been seen at Sound Family Medicine. Those injuries that happened 2 years ago, a year ago, 2 months ago, we're not going to accept. We're going to take new injuries.
So if they're already a patient here, though, if that injury happened a week ago, you're only talking for brand new patients to Sound, or just all patients?
We're talking injuries. So all patient injuries, except for our ERs. Right, so we'll get there.
Right.
Right, so we'll get there.
And that's the reason why it's 48 hours. They can go to the ER and still come to us, but we really don't want them coming after they've been to another physician and then coming in.
Right.
Other than the ER.
No transfers. Okay.
So in the second point, we have the special note if they've already been, oops.
Sorry.
If they've already been seen by another physician other than the ER, do not schedule them. Okay? And we do not see workers' comp patients that have come from other practices, and we are not going to be reopening claims. Okay? They'll need to go to an occupational clinic. Okay?
Even if it was a claim that we opened at Sound Family Medicine?
If we opened it, we have to approve it to be closed. And so we're not going to go back and reopen something because we'd have to say that we closed it in error. So if Sound opened the claim, the doctor has already signed that this claim is ready to close. And so because the patient's requesting it be reopened, the patient has 60 days to fill out an application with the state. Sound doctors are not going to do that. Okay, to get them out of the paperwork.
What about if it's 2 years later and they're trying to reopen it because they believe their conditions worsened?
Right.
What are we supposed to tell patients?
They can go to an occupational clinic.
Okay.
Yep.
So we should probably get a referral from the provider that's treated the patient, or if
Okay.
they're continuing to treat the patient, we're going to refer them to occupational. Is that what
If-
he wants to do? Okay.
Renee, what's the basis of this
To get them
decision?
out of the paperwork. Once Sound has closed the claim, how long does it take to reopen a claim?
For the patient to appeal their closed claim, it takes 60 days.
And how many of those are being overturned, those closures?
Wow.
Right.
A lot.
So,
I mean, a lot of our providers are filling out applications to reopen when they don't have to.
Right.
They are spending the time on these claims because patients are not reading their letters, that it's their responsibility to write a letter themselves to appeal and to state why they feel their claim should be open.
Yeah. So
They're
if
just
they want
going
to do that,
and
patients want to do that,
they're bringing in that application to reopen, and I've got doctors going, well, no, they got stung by a hypodermic needle or whatever, and their claim got closed. Well, yeah, that's L&I's process, though. They open and shut it with knowledge that the patient's going to come back in 3 months, but it's done already. And then we've got patients, does that make sense? We've got patients coming back in going, whoa, I still need to come back in 6 months for another blood test. Okay, but your claim manager should have explained that to you. Your claim is closed already, with the exception that, yes, you know, your claim manager knows that you're coming in for a follow-up for blood work. Now, if a claim gets closed because our provider believes that they're at maximum medical improvement, and 5 years later the patient's like, you know, my elbow is really, really sore, that's what I'm questioning. If we open, close the case, they didn't get any kind of a settlement for it, and MRI shows that their claim, their injuries worsened, we're still gonna turn them away?
They can go to an occupational clinic to
Okay.
reopen. They really, yeah, and that's gonna be the exception, is when you get something like that. And if you have a provider who says, hey, I really wanna do this, then they can be in charge of taking on all that paperwork.
I would say if it's been over a year, let the doctor make that decision. Does that sound more reasonable?
Yeah, and we,
Because the others are typically less
The
than a
others
year.
are typical,
right?
yeah,
Okay.
it's just, I think it's just knowledge that our schedulers and our front office staff understand that when a claim is closed, if a patient comes in and goes, I got this letter, my claim was just closed, I want my doctor to reopen it. Well, it's June 1st, and it's now July, you know, the letter was dated June 1st, it's July something, it's your responsibility to write a letter. You can see the doctor if you want, but it's gonna be billed to your private insurance, because your claim's not gonna be reopened unless you take that step.
so putting that paperwork on the patient where it should be, having the patient be responsible and own that paperwork instead of putting all of this on the providers is what we need to do. So
Okay.
the providers out from under this paperwork, or they're not going to take any L&I. So we really have to get it streamlined.
Okay, so we want to be saying to patients, you know, if you alone can reopen it, right? You should, you know, that's
Appeal
how
that.
you your letter. And also, if they're established already with us, we should let them know that once they have that paperwork done, they can call us for a referral for occupational? Okay.
Yep.
Do they have to have
Do
a
they need a
referral?
referral for
No,
occupational? I
they don't
think
have,
so.
they don't need it, but if you
But
wanted
if they
to.
want to reopen and they want follow-up, we're not going to be doing that. We're going to make the referrals occupational.
We don't have to make a referral, they can just contact occupational.
Okay, they can do it on their
Right.
own.
Right. Trying to get back to the primary care, not the occupational medicine. So with occupational clinics, they are specialized, and sound is like, you know, their same day clinic. We're doing the quick acute injuries. Okay. Try and the same thing with her with the COE meetings. They want to get these patients back to work. Okay, so moving on.
Reception.
Reception. Patient presents with a workplace injury. Determine if they're self-insured or if they're through Washington State Department of Labor and Industries. So I'm seeing I'm seeing if they're self-insured. Sometimes we're not checking and we're still getting accident reports. It's gotten better since May, but really verifying that employer. Is that employer insured through the state of Washington, or are they insured through a self-insured, and building that case. And when you're building the cases, there's a little box that you have to click that says workers' comp. And it seems like there's still some confusion on when to click the workers' comp box. So you click the workers' comp box on every single workplace injury. Okay, not just self-insured. You click it for state and self-insured. Okay, we're building that case. Questions there?
And that has to be clicked.
Has to be clicked or you won't get to the next screen and you'll have to start building your case over. If you don't click it right when you're building, we have to rebuild cases. Okay, so having your patients fill out the proper claim form, state or self-insured, there's 5 things to look for, and it's the specific date of the injury. So you're really going to be watching that date. Advising the patient before they fill out their paperwork, pay particular attention to your date of injury, the time of the injury, place of the injury, the body part injured, and the patient's signature and date on the form. This is the top 5 reasons that we're seeing that these claims are sitting in undetermined statuses, because the state or the self-insured employer is going back to the patient saying, where were you hurt? When were you hurt? What time were you hurt? Did anybody see this? So having the patient be thorough will also save sound time, being that the case is open. If
So
the
it's
case-
this little, sorry,
That's okay.
this little check mark?
Yes,
Yeah.
that little check mark.
But
is
because,
paper.
because I didn't do a new one, maybe.
Excellent. So when you're building these cases right here, cases override medical insurance. So when you're building
Oh,
this
so that's the only
case,
time I can mark that.
you have to check that workers' comp box to get that workers' comp tab
Every single time.
every time, whether it's state or self-insured
Or government.
or government.
Yes.
Yeah, anytime there's been an injury at work.
What you're going to see in this name field now is you're going to start seeing the word verified. That means that we have confirmed that the employer is correct, the self-insured, the state is correct. We have verified this case is either open or closed. You'll start to see notes in the case here.
You're not doing that.
You're not
You're
doing
not
it,
doing
but
it.
you'll see verified.
On their subsequent
case
appointments, yeah.
Right. After all the paperwork has hit L&I, you know, so after a week or so, we're contacting them. We're verifying that it's been received, the ICD-9, all the information that they have, the date of injury, and all that matches up.
Okay, so you'll start to see that word when you're looking at those cases, and you'll still see the body part and the date of injury in that case name, but you'll also see verified now. If patients have if they're federal employees or federal workers, they are required to fill out their workers' comp initial report of injury at their employer's HR office. So Sound doesn't have that form, the patient needs to bring it in. So if they don't have that form, you can register them as self because it's patient's responsibility to bring it to Sound. So I'm getting emails that say, this is federal, bill it, it's workers' comp, but there's no information. The patient's still responsible to bring that information in. Okay?
Yeah, we cannot get that. We cannot get that information on the L&I website. So if you guys can't get it, I mean that just happens sometimes if the patient doesn't bring this in. But if you send an email and say go ahead and bill this, well, we can't just send it off to the state because that's not who pays it. So without a case number and without that paper from the patient, if they are a federal employee, we'll just bill it to their commercial or bill it to them, and then probably when they get a statement, they'll go ahead and give us a call and give us their information.
We'll light a fire under there.
So, you know, it's important for phone ops, as you're talking to those patients or at the reception, to try to warn them ahead of time, we need you to bring this information in. Or if they can make a phone call to get the information, is that sufficient?
That's what I said. I said, if they're waiting, have them make a phone call. Call their employer and say, I need to know who my workers' comp is.
They can
FedEx
certainly
and
try.
UPS are like the hardest because they're all individually, well not UPS, but individually owned. And FedEx can be owned by, I don't even know how many different Sedgwicks, or
Right.
it just gets hairy. I mean,
Yeah.
But it is the patient's responsibility.
Yep.
So don't take on too much, like we were saying earlier in the video.
Right.
And I don't want to jump ahead and make this disorganized for you guys, but we've started with some of the employers going into your employer setup in Centricity, and what do you call it? You don't call it file maintenance, that's what I call it. In administration.
Yeah.
And attaching the correct, if it's a self-insured employer, we're attaching the correct workman's comp name and address.
It's like multi-care is self-insured. There was 23 multi-cares out there, you know, multi-care here, multi-care there. Multi-care is one
It's one
employer
employer.
with one self-insured multi-care. So it makes it really easy. Now, if you pick multi-care, you're going to, oh, there's 3 again.
No, it was home health.
Yeah.
It was
Okay.
something, yeah.
So
was
it goes through
different things.
multi-care risk management.
But see how it defaulted this insurance company?
And down on the left.
So we're building this behind
Oh,
the
and right
scenes.
Yeah.
So if you have the employer on the account, multi-care, it's going to start populating for you.
But this is just in the beginning works, so we really need you when you're checking them in and building this case to make sure that we have the right insurance carrier in case management right here.
the correct address too. Make sure it
That's how
matches
you
with that
want them to check,
self-insured
right? By address.
list.
Yes.
Yes.
Address. And also on this screen, so while we're here, when we go over to the Visit Info tab, we want to watch this allocation set 100% insurance and this financial class industrial. All of those phone calls of patients, I'm getting a bill for $20, this was supposed to go to my L&I. The allocation set, that 100% insurance will stop that. And the financial class industrial.
Right down here. That's what they need to be. That's what you're looking for.
We came across people that were L&I, but the whole bill was set to go to patient. So just needs to make sure.
So, and I want to say that if this hadn't been here, I don't know that this would happen, but no, that didn't change. So I think it's from that initial time that you open up the case management. And if things aren't set right now, which is probably what's happening to you guys, it's defaulting with the incorrect information right now. We're trying to get it so that when you select the employer, we have the carrier in there, and it's going to default to this right information, but we need you to go in and verify that it's 100% insurance allocation set and industrial insurance financial class.
If the patient has been seen at any other facility, including the ER, prior to arrival at Sound, the patients are required to fill out a transfer of care card. So the state only wants one attending physician. So if the state has the ER on file, the state's going to mail everything, all of these decisions, to the ER. If the state needs something, they're going to request it from the ER. So it's really important to get that transfer of care card completed by the patient. Sound cannot complete it. The patient must complete it.
And can I just
Yeah.
interject something?
Yeah.
If they go to the ER first and they come here, we will get paid. The state will pay us. But when you guys have a pretty big volume of L&I, I don't know if everybody's aware of that, but well, whatever.
Yeah, already is.
But so I spend a lot of time going onto the L&I website and just confirm, and see if some diagnoses are denied or if we've been able to get other ones added and different things like that. So even if a patient's been to the ER, and even though we'll get paid, I can't view any information on that patient's claim if the transfer of care card hasn't been filled out. So yes, we'll get paid, but it's really difficult and time consuming. And I've been crunching some numbers on your L&I. We're doing more work to get this paid than we're getting in reimbursements.
Oh yeah.
And you know, ortho, where I was at prior, super heavy in L&I, and I won't mention the practice, but they had just a rockin' L&I AR. It was awesome, and I know you guys can get there.
Right.
You know, I just know it, and I'd like to show them up if we all can, please.
What?
I'd like to show them up if we all can.
Also, don't forget to get the commercial insurance. If these patients are denied, a lot of times there's no other information and we're trying to track down, is there another insurance we can bill? So if there's commercial insurance out there, get the information as well. So you're building your case, you're attaching your case, but you're also registering their commercial insurance. These could be denied. Okay, so just remember these cases, just because the patient says they're hurt at work, doesn't mean their employer is going to agree. Okay, so if
Yeah,
we
we
have
definitely
medical,
want to get that medical insurance.
get the medical insurance.
What will be the preferred route then, say a patient doesn't come in with their self-insured information that they needed, so will we automatically pick the health insurance or try to bill the patient first so that they'll get us that information? What's the first step in that scenario?
If they come in and we can't verify employment and we can't verify an injury, say it's in the evening, it's 7 o'clock at night, get their medical card if they have it, bill medical. If they don't have medical, register them as private and collect private, and we'll get to that too.
Well, I guess there's providers who will turn them around, who will tell them they need to do an L&I if
Right.
they hear that it's work related.
Right.
So
Right.
if the provider does that and that's not what was going on, then we weren't able to verify that after hours.
We can always refund.
Oh, are you talking about a patient that doesn't tell you their L&I and
Right.
gets back there?
No, some people come in and say that they'll say that they're not sure if it's caused because of work.
Oh,
They'll go
okay.
back in the room, provider will tell them, hey, we need to do an L&I case.
Yeah.
Send them back out, they can do the paperwork.
This is
Yeah.
my
Well,
But that-
the typical, the rule is, once the patient mentions work and they're having a problem, which is the only reason why they're coming to the doctor, you are gonna go ahead and bill L&I. And L&I, if a patient thinks they may have an injury or something and it wasn't like they broke their arm to where it was just obvious, L&I pays for the first doctor visit to determine whether or not there is a case. So even if the case got denied, the first visit is going to be paid by L&I, as long as we were the first physician to see that patient. So they pay for assessing the patient and determining whether or not it's an injury. So we should still get paid for that first one, so the doctors are correct. If they even mention they think it might be work-related, we've got to try to send it to L&I, so get whatever info.
Does that apply to if they've gone to the ER and seen someone, are we still gonna be paid for the first visit?
We wouldn't be the first visit, then the first visit would be the ER.
Okay.
Yep.
So first visit overall.
Yep.
It's same day, as Tony was
Well,
saying.
that's-
They come, what if they come in and they don't know, they don't tell the check-in that it's a hospital and it's not till they get to the back. What does front office do to change that and add a case? Can they already, since they've already checked them in one way, can they undo that and
Great question. They can add a case. I was just emailing with somebody about that today. You can add a case after the fact, so you can go back and attach that case.
okay.
So as soon as you find out it's L&I, you can build the case, and then when you're on that ticket, you can add, or you can remove the case, or you can add a case. So when you're scheduling, you'll see those binoculars blinking if the case is already built.
Deanna, you just asked after they submit.
Yeah, they didn't say on admission that they.
And we can always,
So does everybody know where you would go to get that ticket if you've already checked them in? That's, remember last
Can you show me? I don't know where to go.
Well, because they're not,
and remember, you can always refund the patient.
okay.
For their insurance.
So you would end up, you would go into case management just like you do, add all your stuff in the registration, and then you would pull the patient up in the billing screen and go into that date, into that visit and add it there. So they don't go into, you guys, front office, you guys don't go into the billing screen a lot, right?
Do you go there for payments or balancing?
Just for balance.
For balancing? Okay, thanks.
So once that case is added in registration, then you have to go into the billing screen, find that date of service, and then go into the visit info tab, and it should be, where is it charged? Right here. You can add it here. But it has to be built as a case first in registration. Then you have to go to the billing screen, find the ticket for that date of service, go to the charge tab, and then select your case there, and then you have all the cases for the patient. Okay?
And if something needs to be rebuilt and we go in and add the case, should we still email the billers and say, please rebuild this?
Yeah.
Yeah, because we actually have to change the status of the ticket to resubmit the claim out. Yep.
Okay, and if you have a patient that is, again, if it's late and that you can't verify, you can also refer them to the ER if you can't verify. So you don't feel like you have to take everyone on. Okay?
With what?
If you have a patient
Sorry.
that you can't verify, their employer, they don't know if it's state or self-insured, and they don't want to pay, they don't have
They don't
medical
have commercial
insurance.
insurance and they don't have any cash on it
You
either.
can get that case and
Yeah.
right. Right. If they don't want to pay, they can go to ER too, so you don't feel like you have to take everyone on.
Are they allowed to refuse service?
Can they do both?
They are allowed to refuse service. They would tell the doctor, they would tell the provider, patient has no means of paying us and has no means of,
refusing service.
yes,
Okay, not the front desk.
right.
Can they
Right.
fill out both forms?
If you can't verify it, if you don't know, if you can't verify,
We were told before that they could, so I didn't know.
What both forms?
they're
Oh.
doing state and self-insureds. They really should be able to verify and not just take a guess.
Why aren't we able to verify? Sorry, let me go back to the beginning of the,
Because if they tell us who their employer is, we should be able to go to the L&I website and see immediately if it's self-insured or not.
right, so why are we not able to verify?
Yeah, but there's some time frame taken on it. I don't know why.
Oh,
Call the employer, yeah, you can call the employer.
okay,
If it's
so
7 o'clock at
if
night,
if it's our issue, then I think that we should go the extra step and say, I'm sorry I can't verify it. We're trusting you. Get some ID and stuff. And I would say, oh, well, we're trusting you, but give me everything that you have. And have both forms filled out. I mean, I think, but it should be very rare that we can't go in and verify
And
like
Well,
that.
I guess I'm wondering why, I'm all for using the internet as much as possible, but these are single screen stations. They don't have double screen, right?
Right.
They're front, single screens.
Right.
So even though we're giving staff the resource to be able to go to the L&I website, I don't want to speak for you guys, but I'm wondering how realistic that is when you've got a bunch of patients in front of you and you're trying to do a bunch of stuff. Just flip over, log in, hope you don't get logged out, and all that stuff.
What's the option?
You don't printing out the self-employed list in a little binder in every
Well, let's do that little binder.
Tamara has an idea, guys.
Well,
You don't have to log in to look at the list.
You don't have to, that's true.
No,
You can
so
go right onto the
it's actually, it's really quick. You have the.
How often do you
But I'm
check
hearing
it?
that the computers are down.
Slide down.
How often does it change?
Tamara, could you send out that
Not
PDF to the front office so they can save it on their desktops?
That's a good idea.
That'd be
Should,
perfect.
I think they're gonna start
Yeah.
doing it at NEOs too.
Yeah.
Or on the intranet?
Go to the intranet.
The intranet would still be up, wouldn't it?
Computers are not working.
Well, in the event that the computers aren't
In the event that the computers are not working, you still need something at the site.
Yeah, Marcia, we'll get the printout.
Yeah.
We'll get you a binder.
Every location should
Yeah.
probably have the binder, but how often did you say it changes?
Hardly ever.
They send
I don't
updates.
know
It's pretty
what-
static.
Okay.
It's,
Okay.
when I called the last time, it was like a year ago, and they said we updated every week. However, I
Nothing
don't think
changes.
That's only if
Yeah.
they change.
Exactly,
Right.
exactly.
But you
two-
do have to also watch, I'm sorry to interrupt, that some of the self-insured do have dates. It's from here to here.
Yeah.
Right,
So if it ended in
Yeah, you have to watch the
2011,
date.
it'll say
don't
that,
do that for 2012, you need to look elsewhere.
right. You gotta make sure the date says to present.
Yeah.
But it does give you everything you need if you
Yeah,
just
it
read
has-
what is on that employer. So
Yes, it does.
I think it's a good deal.
And
Yeah.
it's quick.
Yep, so 2 resources. We'll get one printed out for every station. And
And I'll send-
Tamara will send out the link to the PDF. Okay, clinical stuff. So now the patient has gotten checked in and got past the front desk, and they left their credit cards, their ID, and their car keys at the front, right? Going to the back office now.
Do we still have questions about the last topic? We have a lot of conversation going on. Are there still questions?
I'm just thinking if we print it out, then we don't know that it's gonna be valid. If it actually
You're gonna have, it's gonna be a better bet than not having anything, right? And making a guess.
Well, I would ask too then, so you have the L&I
Let's just guess.
website. And what I think I was hearing was there was some concern back there that maybe people couldn't get to that because the computers are down or different things.
Right, which should be rare.
So I offer a help, which is to say maybe we can print it out and send it or
Right.
to each station.
Right.
So maybe that won't be current. So I guess I would ask, what suggestions does staff have that would work so that we can get the correct information every time? Because we've tried to come up with a couple of scenarios of how that can be done. And I think I'm hearing that that's not, there's
Well, I
still
think
word that that's not going to be sufficient.
I think for one, we don't want to spend too much time on something that should be a very rare occasion. So I would say, for one, that as you're checking in an L&I patient, if something comes up and for whatever reason you're not able to verify, computers are down, you don't have the hard copy or whatever, resort to getting both forms if you want, but I would clearly indicate in the registration notes what the situation was. Because as soon as we get a denial or we have an issue with that, we're going to come back to you and ask you what happened.
So it's important.
Because we can't keep losing money that should be payable. So I would just ask, do your due diligence to get the information. We're trying to give you the resources, you know, at the tip of your fingers. If for whatever reason something happens and you can't do that, do your due diligence. Okay?
There's also, if it's Monday through Friday, like 8:30 to 4:30 or 5-ish, there's a self-insured phone number. And you can just call them and say, I have this patient here, this employer, and they'll say, oh, it's not on our list, it's state, or they'll tell you where it goes.
So we'll get the phone number
You
too.
can call the employer,
What,
say
you said
call-
that was during business hours?
Yeah, that
Okay.
is only during business
Okay.
hours.
But
Because it's
still-
actually at the, it's part of the state.
There are a number of ways to get credit.
There again, most of our hours are during business hours.
We should be able to get this, yes.
So, okay.
Okay, moving on. So now, like I said, you have the car keys, the ID, right? You have everything on this patient. They're going to the back. Once they fill out their paperwork, the MAs, the clinical staff, will be faxing the report of injury to the state within 48 hours. That's required by L&I. They'll be scanning the initial report of injury and other physical evaluation forms into the patient's chart. Artie's been buried with this. So as Artie's going to go out, she's going to help the MAs get these faxed.
And we did recently learn that all but the initial report of injury can be created in our EMR
And I'm working
and
on
used with electronic signature.
that. And I'm working on
So
that.
we're working on that. Just the initial report can't. And because it has
Right.
that card and all the
Right,
triple
right.
copies and stuff. So,
When are you wanting that switch over to clinical doing
Yesterday.
clinical isn't doing this right now?
that? Oh, it's going to Artie.
Who started?
Well, no, they're faxing
No,
it.
they're faxing.
They're faxing it. I know we're working with, Mr. G, I know, has worked with a couple in the same day clinic. One or two, I think, gals are learning how to start to do the bottom, and then if they have any questions, they're coming and talking to me about it. But so far, it's very, very new. Very, very new.
Well, that's on the initial reports for the Kogi, not the.
It could be it's gonna be for self too. Because the King County is now actually starting to probably go Kogi. So self-insured are also looking at possibly going the whole Kogi also.
Is that?
Okay.
It's just
Another day.
Kogi, in a few words, is a organization that the state is using to try to get injured workers back to work quicker. Because the longer they wait, the less apt they are to return. And so they're trying to be active in getting injured workers back. And so there's a program, they try to get them, they work with L&I for the first 90 days. And then they're no longer involved.
Oh, okay.
And so our providers, most of our providers are Kogi certified.
So getting the information into the patient's chart, getting the information to L&I self-insured quickly will help this whole process. Using the information that you have on your workers' comp form, what the physician fills out, you're creating your update. The form is actually called the WCC form right now in EMR, but that's the clinical staff we're gonna have a name change on that form.
Well, we don't have clinical staff here.
But they're going to start
But
putting
we're
it in
just
the
kind of
patient's
letting them
chart.
know what the clinical staff's going to be
flow.
doing.
But, I mean, do you want me to try to pull that up?
No. But just so you know, it's going to be in the patient's chart. It's going to start pulling into the chart notes.
Just like there's a case in the Centricity that we use on our side of it, in the EMR side, there's also a case built. So that when the patient comes in, the clinical, the MA or whoever will just pull that case for the doctor, and it's right there for EMR for him. So it's just a match to what we do on our side.
Then make sure that if there's any referrals given to the patient that they need to go to see a specialist, they need to get to the ortho, make sure the referral coordinators know. Okay, providers in our workflow now, so the provider gets to see the patient, set the plan of care. They're going to complete the claim forms. They're going to be paying particular attention to some of these bullet points. If they're choosing, kind of our last one we're saying here again, is if they're choosing to treat the patient for L&I and for a non-L&I related issue, on the same day, they're going to dictate separate notes, one for the medical payer problems and one for the L&I accepted conditions. Okay? Okay?
Does that need to be two separate visits in the practice management as well then?
Yes.
Yeah, so exactly. So that communication between the provider, the nurse, and the front office again. The patient tells the front office they're coming in for L&I, they get in the room, they're there for their shoulder for L&I. But by the way, something else is going on. Dr. Treats was going to open up a medical ticket. So really opening up the communications. We're talking about having an MA checkout point to help with that. Having that patient check out at the end of the visit.
My question is, what if the front office staff doesn't know that the patient's going to have a split visit? What if the patient gets back there and says, oh, I'm here for my L&I, and then they're halfway through the visit and he says, and I have, erectile dysfunction or something? How is that handled then? How does it come over for or a cold? I mean,
Right.
That's something that's just been regular.
Right.
If they went back there, they can come out, we can always add a second visit to the schedule.
Exactly. And it's just communicating back to the front so they know that there's two.
And if it doesn't happen, our charge entry better be finding it.
Our charge entry is reviewing more and more notes. Yes.
I don't know what you're talking about.
That's right. That's right. And we have more people working on charge entry now too. So going through the process, it's going to be good. Okay, self-insured paperwork, the APFs, only one is authorized with self-insured unless they request more. So that will save on paperwork. Okay. Drug screens are not requested by L&I, so therefore they are not covered. So if the doctor wants to provide one, that's the doctor's choice to stay compliant with state pain management, but it's not required by L&I. So L&I is not going to cover them.
And we
Okay.
wouldn't,
We wouldn't anyways, like if a trucking company, if a patient says, I don't wanna go to US HealthWorks, and their company's saying, you know what, you have a post-accident UA you need to take, they'll have to go to US HealthWorks to get it paid for.
Right.
If they choose to see, let's say Dr. Stout, because that's their doctor, and Dr. Stout does not have to say, you need to have a UA, because South MMS is not gonna pay for it, but US HealthWorks will. They're contracted with that employer.
Right. You guys hear that?
But it's the patient's choice to see
Some
which doctor
employers,
that they wanna
right,
see.
some employers have contracted, and they've said if any of our employees are in an accident or injured at work, we want a drug screen on them. Those are contracted with US HealthWorks most of the time, not at Sound. So the drug screens are not covered at Sound.
well, we do, I was going to the drug screens that we do. Are those the same?
Well, if, like
For
you
our,
were saying,
our
Dr.
chronic
I
pain
don't know why
management.
we can't contract with L&I to do them ourselves.
Provider-owned lab, they won't do it.
Oh,
Yeah. They will not contract with us.
so just something that's not a provider.
Right.
Yeah.
L&I
Yeah.
will contract with the doctor and say, okay, I'll pay for opioids for this long, as this patient maybe has a drug test every month when he comes in or she comes in. Then that's different. I'm talking initial UAs, if they're coming in for an injury.
Well, maybe perhaps we should contact L&I directly and talk to them.
Yeah,
about
we're
that.
gonna have
We'll
to-
work on that.
Yeah.
So I guess my mind was going to, do we bill L&I for the drug screens that we do, because we require our
Yes.
chronic pain management
Yeah, I
patients?
think they're not
Yes.
covered though.
Yes.
Right, but they're not covered.
They're not covered.
Right.
We
Which
bill
means
medical.
we can have
Bill
the patient pay upfront, yeah. or
We could bill medical
Or
or.
simple care, or prompt care.
But all those patients need to know that, they're there for
Right.
their L&I visit, and so they're not gonna be expecting that something's gonna be carved out and sent somewhere else.
Yeah, because typically, when we do that, it's random,
Uh-huh.
and it's at our discretion. So I don't know that we would set it up to bill L&I.
Well, just
Because
because
we're
they're
not
charged,
doing
just
it,
come over.
we're doing it because they're on chronic pain meds. Stormy, what?
Well, I think just a couple days ago I attached the case when I did a random talks because I was like, oh, you don't have insurance, and I was gonna charge him the 22, and he's like, no, it's L&I, so I attached it. So is he gonna get a $300 bill? Yep.
Yeah.
So can we mark him down when we see that to the
Or-
simple care?
Or should we do
Oh, I don't see
a
why you
prior
couldn't.
off and do
Once he
a
pays the
simple
public
care
service.
or whatever?
Yeah,
Well, I
yeah,
mean,
you don't have
unless
to
there's
prior
some way
auth. That was our question, is can we do it as simple care? You can do it as simple care, because that is our clinic policy, whether or not L&I is asking for it, and I think that's what they're gonna come back and say, is if we're not requesting that drug screen,
Right.
we're not gonna pay you anyway. And so because that's our clinic policy, we can bill them simple care, or allow them simple.
So even if they don't have money on them, because it's random?
What about the ones we already attached and now we're getting the $295 bill? Are they gonna be-
The billers on the back end usually get those phone calls and we'll deal with it.
You got this.
Yeah, we got it.
You got this.
Yeah, we can, but we'll definitely get answers from L&I, but I'm thinking that it's gonna be just like we're saying here. Tell them it's simple care, because it's not L&I requesting that drug test, it's us. So,
Can the patient refuse it?
They don't get their meds then.
Yeah, they don't get their meds.
Oh.
So sure, they can refuse it, we're not do it.
and Stormy, if they don't have the $25 or whatever we're charging for the simple care, are they typically being seen? Or they're just coming in to get that refill?
Yeah.
If they come in to pick up their prescription, the provider's written on a
And
sticky
they
note
can
on their
never wait, they always
prescription
have to go.
that
There's a-
they, yeah.
What did she just say?
They never wait, they have to go. Never wait.
They're puppies in the car.
Then we just need to, I assume that we already have that established, that if they don't pay and they don't have it done,
They've signed the pain management.
right?
Oh, they did, oh.
Yeah, yeah.
They're not getting
So-
the drugs.
No, they
explain
don't
those
get
to
them.
Okay.
Yeah, they're not really happy about that.
No, I've never had to do it.
So in to the billing department now.
Yeah.
Another change, correspondence is gonna be coming to the billing department. Instead of coming over to clinical, it's gonna come directly to the business office now. We'll be verifying that forms have been submitted to L&I and self-insured payers. We'll be sending again if we can't confirm it, so be really clear on the notes if you faxed it. We'll be reviewing all of the information on the case. Once everything is verified, you'll see that verified coming in on the case names now.
So, I just wanted to go to
Before the date of injury, yeah.
where,
Double click.
oh.
Yes, like right in front of that case name, you'll start to see that verified in the person's initials.
Yeah, it'll be in here, but I wanted to show them where's the registration. Where we're gonna be entering in the diagnosis code as well,
Filing.
and,
It was under the filing one.
For visit info, yeah, visit.
so when they verify, they're also going to be verifying the allowed diagnosis code. And so this should help you as billers, because now we're into the biller side of things, right? When a case has been verified for the date of injury and all that, we're calling to verify that we're the attending provider and get all the information correct, they're also going to be entering in the accepted diagnosis codes in the case. And so I think that's also important, because we were talking about sometimes when the patient is seen and they're adding diagnosis codes in. Are we going to be talking about that? So what is that process? So we have a particular diagnosis code that was accepted by L&I from the get-go, and now they're discovering that now there's maybe another.
That they're going to approve? Is that what you're saying? And then we're going to come back in and add it?
Well, so if at the front, or on the back, the provider's seeing the patient, and he's saying, oh no, this is actually related to your L&I condition, what do we do to now get that new diagnosis code accepted?
The physician has to request that another diagnosis be added.
Usually they write that in the APF form, note to claim manager. Considering the hip pain is stronger and she did fall, would like to consider an MRI for the hip, please allow 844. I don't know.
Yeah, and then if L&I is going to allow it, they're going to send correspondence back saying it's allowed. And so that's why it's so important that correspondence get routed to one person who can make sure that
get it to
So the providers know to get that information to them already?
Yes.
And so
sometimes
that's
they'll
why it's critical that we have these accepted codes in here, and now they have that in the EMR as well, right? And now they know this isn't one of the codes that's on here, we need to have this approved by L&I.
And it's perfect for when they, let's say, slip and don't do a transfer of care card, at least we know what's allowed and what's not, because we can't get to their case
Right.
on L&I, let's say. Let's say it was just one that fell through the cracks or something. We got it down.
Liz?
So for charge entry, where do we see them? Because I've been trying to look for the accepted diagnosis codes, and I would say as of right now, especially because it's in the beginning stages, like 95% of the time the accepted diagnosis
Oh,
codes
you're going to see more now.
anywhere to be found.
Yeah, no, you're going to start seeing a lot more.
Case management notes, remember?
Yeah, case management notes, and also now you're going to see them on this screen. So we're putting them in fast, as fast as we can data enter them, we're putting them in. And you're going to start seeing them
And where do we see
initially.
them in the EMR? Because I've been flagging the doctors for those, and all the time they say we don't know what the accepted diagnosis code are.
So yeah, I knew you guys were
Right.
gonna ask me to go there.
So Liz, we need to show you, I need to show you the L&I website. So Tamara, will you show Liz the L&I website, so she can quickly see those?
Well, no, she's going to be in the EMR and she wants to be able to see it in
I
there.
want to be
Right.
able to see.
So I
that
can show her
refer-
where- yeah.
so that I can
Okay.
refer the doctors as
Okay.
well.
Right, if it's not on the case, that's right, if it's not on the case yet, they will all be on.
Oh, right. They're
in the
not all
future.
there.
Right.
Yeah.
So,
But as of July 1st, they're coming on, and we're backloading also.
Well,
Okay?
yeah.
Deanna, did you have a question?
I just have a, yeah, I do. Is what you're gonna continue to cover more on the billing side of things, so that I
Yep.
can take my staff and move them across the hall and try and get 20 minutes with them?
Yep.
Is that
Yep,
okay?
yep.
All right, I'm sorry to interrupt what you guys are doing, but front office and colonoscopy stuff, I need you guys to go right across the hallway.
I don't know.
Are you from office or do everything?
I work in QI.
Oh, you do?
That way we can get you. Yeah.
I don't know the rest.
Okay. Okay.
Okay, we're gonna get started again. I do think you guys should stay because you should know accounts when patients are calling about.
Okay. The only other question I had is back to where we were. She said that adding.
Yeah, we're still on L&I. We're gonna check it. Yeah, yeah. We can go back to ABNs if you want from 2 to 2.
That's supply.
APS. Yes. Okay, so we're adding a new diagnosis code to an APS, and it's a self-insured. Well, we're not sending APS, so.
Right, the doctor's gonna do a letter.
They just do a letter?
Yeah, just a request, because the problem is they're not, the staff that's getting those APFs, they're not reading them, so a letter really stands out.
Okay.
Yep.
That's just.
Okay, is that something I need to know?
On
Is
the
that a
self-insured,
change?
well, yeah, so just, it's not really changed, just on the self-insured,
All the time.
they were doing APFs all the time, and they were requesting additional things on the APFs, but because the self-insured didn't request it, they were reading it and just denying them.
Oh.
So if it's a self-insured and you want to add a diagnosis, doctor's gonna write a letter, just a quick one-line sentence, would like this to be considered.
Okay.
Okay? All right, moving on, back into billing.
And it's not billable.
Right.
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 Because they're just, yeah, right.
If they were reading the chart note, the letter wouldn't be necessary, but if they've got to get
But not
surgery, it
for
becomes
federal, it is
especially
if it's
important.
after 10 days.
Exactly, exactly.
Wow.
So, Artie,
Oh my God.
Artie is going to continue though to manage those medical records requests that come in. And if we get those chart notes faxed within 5 days, Artie hopefully won't have as many medical records requests. So those chart notes are always going to be moving to the state when we identify that they're L&I. The chart notes are going to be faxed to state or self-insured within 5 days. But Artie will handle the medical records requests that come in for L&I. Okay. We have Brittany and Jesse really drilling down in the process. So Brittany is pulling up the billing criteria by insurance group, not by financial class. That's important to know if you're helping Brittany. We're getting some questions out there with what she's seeing, because she's also getting some claims that weren't identified previously when there was 2 tickets, and so now she's having to go back 30 days. We're finding that, oh, we got to do 2 visits, there's an L&I. Let's get chart notes. Looking for claims that have no last file date, and then she's looking to see if those claims have been verified. So Jesse and Brittany are working really close.
So basically, Jessie is verifying newer claims as she's getting the new report of injury. And what Brittany is doing is identifying visits for already established L&I cases and trying to identify those and get those verified. So as the patients are coming in, and we didn't have that information in the case initially and hadn't verified, she's going through that process.
Jesse's doing the new ones. Jesse's doing the new ones.
Right, Jesse's doing the new ones as the forms come in.
Yep. Okay, so payment posters, the new process for payment posters is that all of the EOBs and denials are being routed to the payment posters. They are posting 0 pays and pending so that everything is posted on the account, and in the description they're putting the note, pending, denied, so that we know where we can find that voucher or where that denial is.
What?
So payment posters, they're posting 0 pay when they're pending or denied with a description, pending or denied. So as they're posting 0 pays.
In that they're not in the ticket. So this is where we differed over the weekend.
Okay.
They're not in the ticket when they're entering in the payment. So I think you're not talking about the ticket description.
No, the 0 pay amount.
Okay. So she's talking about the transaction type, the adjustment type.
Right, so
Okay.
they're putting in a 0, and then you can see in that description, that little box, if it's denied or if it's pended. Okay.
That's good.
Right, and the claims that are undetermined, the statuses now, as we're getting those notices that are coming in, some of those claims have been undetermined for 6 months, 7 months. We're calling the state, we're saying we need status, state calls back. They've made a few decisions, they've allowed some, they've denied some. But we're deciding now, Sound doesn't have to hold on to those for 6 or 7 months. They're under no obligation. We're going to give the state 90 days to make a decision. So those will be in pending. You'll see the status is on hold Well, we're waiting for the state to decide if they're going to accept or deny the case. But
I
no
think
more
we
than
said
90 days. That's,
6 months. I think we said 6 months.
we said 90 days, and we're gonna go out past 90 days.
What do you guys do?
Okay, well, if we're gonna have this conversation right
Sure.
here now, I think 6 months is, or 90 days is too tight.
Okay, so we're gonna go out further? Okay, so what did we
I
decide?
really do. I think that's just.
So this is a
I
draft.
thought we said, yeah, that's what we said, we're gonna
okay.
talk about it, so even we're gonna debate,
6
okay?
months, okay.
Because if we turn them over too fast
Heads
and
or
build,
tails?
It's right.
if we turn them over to a commercial too fast or bill a patient, we're going to be doing a bunch of refunds and a bunch of other stuff too.
But we're asking for status at 90 days from the state, saying
Oh,
why
yeah,
is
yeah.
it still pending?
Yeah, we'll
Okay,
check it.
it's the
We'll
state.
check it.
Advocate right here, what happens if they have Aetna as their commercial insurance? So if you wait 6 months,
No,
well, if
it,
it's not gonna go to the, if the patient gets denied with Ellen, or it's,
once we get the denial, Aetna will honor that.
Yeah, but we send a letter to the commercial
Aetna will,
insurance
but-
that shows the date
Yes,
that they
they
made
will.
their determination.
Yes, they will.
But otherwise, it's just going to be refunds and a nightmare of you guys.
We've got to get the denial.
Yeah.
Yes.
Yeah.
Right, well, that's the problem.
The
Right, so
state
that's why we're going to payment posters. Gotcha.
contract guidelines, their rules say they have 90 days to make a determination to either deny it, allow it, pend it further, and when they pend it further, they have
Yeah.
to send you a letter stating that we've pended it.
But we don't have to hold it.
Why don't we have to hold it?
Because
for
it's not
a contract with
accepted.
them?
It's
We
not
don't.
accepted.
They have sent us notification. We are not even obligated to hold it for the 90 days.
Only accepted, yeah. So only once they're accepted.
Can I hear that again? Sorry.
Yeah. So only the claims that are accepted are we obligated to wait for payment on from the
Okay.
state. If they are not accepted, if they're pending, you can bill medical, you can bill the
We
patient.
can bill the patient or
You can
medical.
require
I did
it.
verify that.
You got
I have that in black and
Yes,
white
we
from
have
L&I.
black. Yeah.
But we're not gonna do that until we've had it for 6 months.
Okay.
If
And we're gonna
doctor,
check it at the 90 days.
Do you care if we have access to that, what you got, the feedback in black and white, just in case somebody
I
would have?
thought I forwarded the email to you guys already.
I didn't get anything, and I've been wondering about it since you sent
it's a
me.
whack,
Oh.
you know, it's a whack.
Yeah.
You can even Google the whack. Yeah, you can Google the law.
Okay.
Yeah,
Well,
she
same.
sent
Yeah.
information.
Perfect. Thank you.
Yeah, they're not, this,
I trust you. I just like to have the backup because that's how my brain works.
the state is not,
That's how my brain works
Right,
too.
right.
That's why I asked for it. So
and the state's
We
not
have
going
it.
to tell you that that the provider has to go for months on end without payment.
Okay.
So the provider is being
right.
courteous.
So we're not debating that. But
Right.
what we're going to do is we're going to hold it for 6 months. I think at 6 months
That's fair enough.
we're gonna drop it to the medical carrier and bill it or the patient.
And we're coming back in at the state at 90 days saying, hey, it's been 90 days, we really get a decision, and they are coming back with phone calls saying, oh, yeah, sure, let's take a look at it.
Yeah, that's the other thing is once we started calling these people at L&I,
We start getting,
whatever my contacts are, they're getting on case managers and saying, you have 3 claims out there that you haven't made a determination on yet that are almost 6 months old.
so we're
And
getting
so we can
answers.
push them along in those determinations.
Okay.
Mhm. Does that make sense?
question for charge entry, there's several a day that I get that are no L&I info.
Go to private. If we don't have the info,
If we don't have
it
the info
can't.
that day, or should, what if it's,
Patient
because a lot of
responsibility
the
to get
times the transaction notes will say, patient didn't have paper with them, or bringing it in at the end of the week. Is
Right.
that kind
Go
of?
to private, patient's responsibility to get it.
Okay.
Yeah, when they get it into us, then we'll deal with it.
Okay,
But all
so
of these
it's-
requests that come into L&I to bill, if we don't have a claim number and date of entry, we can't bill it
Yeah, I
anywhere. So
know.
it's gonna sit, so patient responsibility, let the patient bring it in,
Okay.
okay?
So for, like, my payers that I only have 90 days on, and if we're waiting 6 months to make a determination, I'm 3 months past. I mean, are we ever we're gonna get a documentation from the state on it?
Mhm.
We will, but
Yeah.
Eventually, we have to receive a denial or acceptance. So with a denial, then your interest will bill based on that date.
Okay.
You bill based on that.
and that's why we have it going to, the denials are going to payment posters now, so right when they get it, it will be in the batch, you can identify it online, and it'll be posted and transferred to medical instantly.
Because you need to print that letter and send it to your commercial payer.
'Cause you're gonna need that
showing
date.
Yeah. I'm a little concerned with Cigna and United Healthcare honoring that. If it's 3 months after it was denied,
I'm looking at some of the cases
It's
too.
not gonna be 3, why would it be 3 months after it's denied?
Well,
No,
it's
he's
not-
saying, they're saying, okay, they're
I'm
giving
saying-
them, for the ones that haven't been accepted yet, they're giving
Right.
them the 6 months.
Exactly.
But then also, well, so I see what he's saying, so like, it's 6 months, They haven't accepted it. We don't have something in paper to send to Aetna because we haven't gotten that final denial.
Well, we can all, anybody can call the state any day and say, okay, you haven't approved this. We need something in writing that states that so we can send it to their commercial
Will
payers.
that be part
And
of
they
what
would-
happens at the 6 months as they're being reviewed? Do you see what I'm saying?
I do see what you're saying.
Okay,
Yeah.
that's all, just the process.
And as we
Yeah.
start to put pressure on them, I think they're gonna get used to us, and they're gonna know when they see sound coming through that they're gonna expect an answer or they're gonna be on the phone.
Okay.
Okay, so we're putting the heat on.
I lost it all.
Okay, we got like a
We were almost at the end
minute.
anyway.
So if the claim is rejected, the patient will also be charged for their paperwork and their office visits. So again, unless the claim is open and allowed, accepted, sound doesn't have to work for free.
No obligation.
Well, we were the first, but a lot of times the state will deny that first one in error.
Right.
Even though we were the first ones.
Right,
And
so
so
we-
you just have to know to call them and say, hey, weren't we the first physician? Because you should have to pay that.
Right, and if we're not the first, tell us who it is. Okay, so that's the new process that's coming down, and this really is a draft. I know that there's typos in it because it was late and we were cross-eyed on Wednesday night trying to write this up. So questions and answers?
And also a question on that they're putting everything from L&I, and I don't know what's being put in hold, but there's been a lot put in hold.
Undetermined, and so that's, their undetermineds are going into hold. If they cannot bill it because the status isn't determined, we have no idea what the ER said
But how long is it gonna stay on hold?
Yeah.
until we get an open and allowed claim.
Okay, but here's the problem with that, and I know you got an email from you today, but I didn't
Yeah.
quite understand. I understand your process of thinking, it's very good thinking. Put it in another status, you guys know how to differentiate what you guys are doing. The problem is that when those are in the charge entry world, when those are on hold status, those hold statuses get pulled into a report, those reports in turn get sent
Yeah.
to a physician.
Yeah, and that's fine,
Why would that have anything to do with them?
because the claims, maybe.
I don't know.
Yeah,
With
I don't know who's.
Who pulls the report?
The
Can they-
hold
What
status,
I've been
what
told
we
is
were
that,
told.
what I've been told is that the stuff that goes into hold is only stuff that has been not signed
Oh,
for 10
okay.
days.
Gotcha.
Okay. So
Okay.
Because that is
So we need to find a different way to
that
handle
is
the
an-
ones
yeah,
that are,
that is
okay.
an alert to the doctors
Right.
that you needed to sign this off a long time ago.
So they're gonna
Okay.
see all this stuff, and Dr. D'Souza's gonna get all of these hold statuses
Okay.
for these 10 patients that they've been in hold for
Well,
3 or
we're
4
gonna come in,
months,
we're working
let's say.
tomorrow, so we can go in and look at that
Yeah.
and see if there's a better way for us to do that.
And
or
I
get it marked.
understand
So
where it's
let us
coming
look at that
from, but
tomorrow
that's
and we'll
what
try
that
to-
hold status is for.
Okay.
So
Okay.
it's to cue the doctor going,
Well,
hey.
and then
Okay,
back to
so
the,
signed.
Gotcha.
back to the very beginning though, if we're only taking new entries with specific dates, specific times, and the doctor completes their portion being very particular, these aren't gonna be on hold anymore. They're gonna go through.
Well, in
They're gonna be
Citrus
moving.
you can actually create a new status
But-
too anyway, so you
there
can
you
find
go.
out
That's
what's
what I was-
specific to what you guys are doing.
Oh,
Well,
okay.
I'm just asking Carol.
But I think we're gonna start eliminating this if we're really thorough with our process and we're very particular. You're
I
gonna see
just
less
would
and
hate,
less of them.
I would hate
Yeah.
for the providers to come back and get all ticked off because they're like, why am I on this report? I have my stuff signed
Well,
off.
I think it might be good for them to know that these cases don't have a decision too.
Yeah, but it's also something they
Two
can-
different conversations.
Yeah.
Well, and I'm not following it, and
That's
I
okay.
can't take
They're-
notes.
Right.
Well, if you hadn't
That's okay.
blown
So
it-
we'll,
I
Yeah, we'll
know.
go in tomorrow and see if we can
Yeah.
do it, put those somewhere else so that
Maybe,
now,
maybe a different status for,
Yeah.
you know, and I think it's good. I think the thinking's good. I just don't want it to come down to, well, we're trying this because we need to have it categorized as such.
And-
But then it's also creating another issue with the providers
you know,
going.
and I think sometimes when we're trying to figure out a way to streamline it, and you guys are doing your
Hey,
real
Kat,
world
it's
job in the real
Denise. I
world,
need your
you know,
password.
we don't understand how something impacts you. You might not
Probably.
understand why we want something done, but these are the things that will
And I
work it
totally
out.
understand it, and I emailed Renee about it because I'm like, what's going on? And she did explain it, and it made a lot of sense. But I thought a conversation,
not the best
face, but I
choice.
thought
Yeah.
a conversation face to face would be better because I'm like, this email stuff, it's like,
I know.
this is the thing. This is what we've been told. This is what the providers are gonna come back and say to us, so.
well, we're really hoping that we have less of this going, that it's very smooth
I know,
going forward.
But if we could do a status that would be
Okay.
specific to that, maybe then we would, that specific status wouldn't be drawn, wouldn't be pulled into that report.
Okay.
So then it wouldn't be an issue. You guys can use it all you want, we can put it in there and call it a day.
That sounds reasonable.
Okay.
Okay.
Sorry, I
You
don't
got no
know.
questions and answers? No, you got.
She can't concentrate, she can't take notes,
We're good.
she's done.
What?
We're done? So no more questions, answers?
Was that it? We got all the way to the end?
Yeah, that's it.
Okay,
But
well,
we still have more to do. But
we had hoped to do some actual case
Oh, never mind.
case study, Q&A, and we're not going to be able to pull it up, but I would say, I would imagine that you guys had some scenarios that you wanted to discuss. Can we just kind of have a conversation about what those scenarios were, how they were handled, and how they could have been handled or should have been handled? Just a verbal discussion around it?
Yeah.
Do you have enough information to be able to do that?
Yeah, the multiple tickets, just going into the chart notes and just confirming that there's no labs, that there's no L&I and a commercial payer, or that there's a commercial payer and a simple care. Really watching those multiple tickets.
Multiple?
The multiple
What do you mean?
tickets.
Same day.
Same day. The multiple tickets.
Oh, before
Yes.
duping it?
Yes.
Yes. Okay.
Making
So
sure-
that's charge entry for all of you that are now pulling in charges. You want to make sure that just because there is another ticket, right, that you look to see, have we captured all the charges that were, or all the services that were provided, and should there be two separate tickets with two separate sets of charges, or is it actually a dupe ticket that you're going to dupe out?
And I think some of that has been too, is that some of it is that sometimes there's not two chart notes.
So we have to look.
So that's part.
So some scenarios, as you know, Susan's working on a project this weekend to clean up the L&I stuff, and I think we talked about that in a huddle, where an L&I E&M office visit was trying to come over, but we saw there was another L&I ticket, and from the surface, that was okay to dupe out, right? We captured it. But when you drilled in, it was already entering in the forms code. And we didn't build the E&M code out.
Right.
We just duped the ticket. And so we have to drill in and look what's on that ticket, look at the chart, what did we do, and what do we still need to capture, or do we just dupe this ticket out?
You know what happened though, for the longest time, Mr. Gibson kept adding the 1040 and the 1073 with his E&M code. And so it took a while for some of the providers, don't add the paperwork. Just, if I don't have it, then I'm not gonna do it. I need to see it in hand.
And so again, looking at those charges that are coming over and what's already out there for that same data service and reconciling it.
And it could be labs, it could be simple
Could
care.
be labs.
I think I missed something here because we have two tickets
Yep,
for
The same day.
same data service.
60 patients and we have to go into every MR, or what am I?
When you have duplicate tickets, you have multiple tickets, go into EMR and look. If you've got to make sure that you're not just denying it as duplicate.
Because what it'll be is, because when you'll see it, Tamara, it'll have a patient with Medicare on one,
Yeah.
and then on the next line it'll say same
That's okay.
patient with L&I.
Oh, but we don't see
No.
that.
For those tickets, yes, you need to go to the EMR
But not for
and
all
check,
of
but
them.
not
Just
for-
duplicates, multiple tickets.
Because, so, I think what she's, because we have a duplicate ticket issue anyways.
Yes, we have a duplicate tissue ticket
especially-
issue.
Oh, you do?
We have-
Especially with our same
duplicate
day.
tissues.
Because what happens is that they get registered at the front with
Gibson,
provider
whoever.
Gibson, but that's not who actually sees them. So
So it
then
creates
we have
another-
another
Yeah, it
ticket
does.
with the provider that actually saw them, and you get.
So you have duplicate tickets, that's what I'm asking.
It was
So here's, for one, those are going to be the same facility, and it's typically at same day. If it's lab, it's going to be a different facility. So I would say, watch what you're pulling in.
And also with those questions when they're coming in, when they're pulling in the charges, and it says, do you want to apply it to a case? And they're not matching, it comes with those little question boxes.
Well,
Watch
but
those
it's asked that
questions.
for anybody who has a case.
Anybody who has a case.
And
That's not closed,
anytime, if you
so-
have a case, anything, L&I or MBA, if you have a case, every single time that person's charges come over, it will always ask, do you want to apply it to a case? So normally, I say no and then go in and check that transaction to see, was this an L&I, was this an MB?
And then go in and that's probably the safer way to do it, using the 80-20 rule. That's probably the safer way to do it, because the assumption is if it was the case, the receptionist would have caught that, right?
Yeah.
But then you do need to check afterwards what that diagnosis code is, after you say no. And then if it is an L&I related, you need to go in and add it.
And we are closing the cases immediately when those notices come in now, so you're getting less and less cases, but I know that that wasn't
Yeah, because
happening
they're all
before.
left wide open.
Yeah, so we're trying to get those all closed instantly too. As soon as we know they're closed, we're marking them. But watch those, because we're finding revenue that was missed, so there's money that we can
But
get.
if that, you know, so this, I'm the newbie in charge entry, so the process is different, like, I'm still understanding it. When, I know, I don't see L&I, I don't understand that.
So can we,
Okay, I can do it offline. That's
yeah,
fine.
that would be a good, more focused discussion,
Yeah.
I think.
We'll be here tomorrow.
Saturday, 9:30 to 3:30 this Saturday. That's right.
Okay.
Yeah, 9:30 to 3:30, stop by and see us, right? We are off the 28th though, so we'll be off the next Saturday, the 28th, we're off, so come see us this Saturday if you want us.
Me too, I'll be
That's right.
longboard yogaing.
I'll be having a birthday
I'm
party.
sorry, what?
Yoga on a longboard.
On water.
On water.
Wait a minute, where are you going, Bahamas to do
Total
this?
sidetrack, no,
Sorry.
Seattle.
In Seattle. Ew, that's
Anything
cool.
else, last minute case examples?
No, actually, because it is 8
Yeah,
o'clock,
yeah.
but I am intrigued about why there would be duplicates from a certain facility.
It's because the doctor name, it doesn't match exactly.
It's because when we, same day,
Yeah.
when we check them in, we don't know who they're seeing.
Do we know who they saw when they came out, so that could be changed at that point, or does that not?
No,
work?
it just makes a new ticket.
Yeah, no, what happens then is we take the copay, and as soon as you post the copay, it locks that.
Yeah.
So then
So you
can't we create a doctor named same day? And that way we always know when that doctor comes over, another one, we're just gonna do
So what
that one.
happens is they're not creating the duplicate ticket. When that doctor signs off on their chart note, it creates a new ticket and
Right.
sends it over.
So yeah,
Right, so you know the same day doctor one is the one that's
So we're
no
shopping
good.
for new EMR, right, back to.
Yeah.
Back to.
You still have new tickets.
This
So
is,
you
yeah, but
wouldn't
what
have to
she's
check,
saying
because
is
you
you
would
know the
know
one
that
that
one
says
named
same day
would
isn't the right
never
one.
be.
But you
would
kind of
always
know
that.
because
Yeah,
if
but
you have a
what
line
about
here
the
that
ones where they actually
says
do check them in
$20
with
on
the
the patient,
same
right? And then you have a
doctor
line here, same
Yeah,
patient,
so
it
that's,
for the charges,
the-
you know that goes onto that ticket. Because
Ellen.
you go to the EMR,
You know, that is worth me revisiting that process again to see how things are working, because I know that sometimes it's got bumped up more than it needed to be. And we were able to start to thin out the amount of
It's
dupes
gotten
that
a
we
lot,
were getting.
It has gotten a lot better. 'Cause I remember there
Okay.
was a time, I would want to say last November, December, where every stinking ticket had a duplicate or a
Yeah.
triplicate.
There's gotta be a
Every
fix,
single
there's gotta be something, a
It's a
workflow or
scheduling,
something.
well,
Well, Durant used to
Yeah,
do
it's
it a little
scheduling.
bit differently,
Yeah.
and I tried to see if we could use his method. But again, some things I think have resorted back to old ways, and it would definitely be worth looking at.
Yeah.
Denise, I want to know more about your longboarding yoga. Where are you going?
It's someplace in Seattle. It was a Groupon. It's the first Groupon thing I've ever
It is a
purchased.
Groupon, and it's, I've not done that yet because I'm scared that you're gonna get this thing and you're gonna go and they're gonna go, what?
Are you doing it alone or with somebody?
No, Lisa is gonna do it, and I signed Brittany up without her.
And then Barb and I are gonna take the boat out to
Without
lunch.
them,
Yeah.
So what,
I just emailed her and said, guess what we're doing?
what lake is it on?
I don't know. I'm gonna show up and they're gonna put me in a wetsuit, I hope, and then we're gonna go out.
So
And then I'm gonna land in the water most of the time.
It's all about core.
So it's just for the day?
It's all about core.
It's like an hour, if that.
Yeah.
Core is.
Yeah. But that sounds
I
about
need that. No, it's funny that you said that because I was online last night at Amazon looking at yoga. Because
okay.
so I was just looking to see.
Bye guys, have a good weekend, thank you.
And yeah, it was interesting you said that.
I do I do hot yoga at Prime Fitness in hot yoga. It takes, I think.
Okay, yeah, I'm gonna have to start slow. But I thought it'd be really good thing for me to see the email I sent you about that other relaxation. Perfect. Okay. Because Abby's thought I was thinking, I'm just showing. So I'm trying to find something out.
It is But you really have to, I mean, because you could just go and it not be as relaxing. I mean, you have to, I believe in bioinformatics and stuff, and you have to find relaxation. You have to, you know, be willing to, when they tell you to, whatever the position is where you're supposed to be not thinking about everything, my mind's like, and I really have to focus and try to let it all go and allow the relaxation. Yeah.